Okay, well, didn't get anybody else, so why don't we go ahead and get started. My name is Brent Logan. I'm going to be talking about designing clinical trials. And as I mentioned, feel free to stop me with any questions that you might have, but please speak up if you do have a question so that I can hear it clearly. Just speaker disclosure, I don't have anything to disclose. What I want to talk about today is designing clinical trials. I'm going to start with an overview of the different phases of clinical trials, phase 1 and phase 2 trials, and then I'm going to focus the remainder of the time on phase 3 trials in terms of the aspects, major design aspects like endpoints, eligibility, randomization, blinding, power and sample size calculation, data monitoring, and some alternative study designs. So there's a lot to cover, but hopefully we'll get through it, at least on a surface level. My background is in, I work as a statistician for the Blood and Marrow Transplant Clinical Trials Network. So my background is mostly in that area, and so some of the examples that I'll be using have to do with bone marrow transplantation, but I'll have some other additional examples that hopefully will be a little broader in scope. So in terms of the phases of clinical research, the ideal clinical trial that you would want, which would be a definitive assessment of the value of an intervention, refers to a randomized, double-blinded trial. That's what you generally refer to as a phase 3 trial. There's generally 4 phases of research, and the first step, you're trying to establish safety and determine what an appropriate dose of a drug, if that's what you're studying, as well as possibly to do some PK studies. These are usually the first trials in humans or in a particular patient population. Phase 2 refers to a stage where you're trying to look for some kind of efficacy, some kind of biological activity of the treatment, and determine whether you should be pursuing that particular treatment. Phase 3 refers to the kind of classical clinical trial, a randomized comparison of 2 or possibly more treatments. And then phase 4 is the long-term surveillance in a broader population, looking for unexpected side effects or toxicities and so forth. These are not rigid criteria by any means. There are often hybrid phases where you're looking at phase 1 and 2 or phase 2 and 3 trials. So let's talk about phase 1 trials. So phase 1 trials basically how well is the particular treatment or the particular drug tolerated? And you start off with small numbers of individuals since it's an initial assessment of the drug. There's usually some kind of screening for toxicity and a determination of a maximum tolerated dose if you're studying a drug. There's sometimes a distinction between phase 1A and phase 1B, referring to healthy or diseased subjects who are failures on conventional therapy. These are generally small studies, less than 10 patients per dose. There may be a dose escalation plan or a de-escalation plan to try and hone in on a particular target dose. Again, here efficacy is measured, but is not the main objective of the study. So what is a maximum tolerated dose? Maximum tolerated dose is the highest possible dose with an acceptable rate of dose-limiting toxicities. So this is something where what is an acceptable rate? It's something that's set by the investigators as a trade-off for the potential of the patients to benefit from the treatment. The one that's commonly used in cancer clinical trials is the dose which produces a grade 3 or worse toxicities in no more than 1 in 3 patients, as just one example. But that's by no means the only one that you would want to use. So the reason is, so we're expecting some kind of a dose response. So we would expect that the probability of a dose-limiting toxicity occurring in a patient is going to increase as the dose increases as well. So in that example, the cancer example that I mentioned, the target dose-limiting toxicity rate would be about 30%, and that refers to that point on the curve. Okay, so the target maximum tolerated dose would be around 6 here. Now in practice, we're not necessarily evaluating dose on a continuum. We may evaluated in a series of doses. So the dose levels considered are on the top of this curve. We may start at dose level of 1, and then if we escalate, we may double the dose or have a 100% increase, and then go to 67% increase and so forth. That's one particular way of dose escalating called a modified Fibonacci sequence, but there are many others as well. So in this, among the evaluable doses here, dose 4, which is the highest dose with a dose-limiting toxicity rate below 30%, would be the maximum tolerated dose. So how do we design a study to evaluate the maximum or identify the maximum tolerated dose? One of the classical ways of doing this, especially in the cancer setting, is this 3+3 design. Here patients are enrolled in groups of 3 for each dose level. If none of the 3 patients experience a dose-limiting toxicity, then you would increase the dose level. If one of the 3 experience a dose-limiting toxicity, then you would enroll an additional 3 patients. If more than one of the 3 experienced toxicity, then you would stop and identify the previous dose, if there was one, as the maximum tolerated dose. If you do need to enlarge the cohort from 3 to 6 patients, then you look at whether less than 2 out of 6 experience a dose-limiting toxicity, in which you would escalate the dose. Or if 2 or more out of the 6 experience toxicity, then again, the previous dose would be considered the maximum tolerated dose. This is a fairly commonly used design, especially in the cancer setting, for evaluating cytotoxic drugs. Now here's a simple illustration of how this works. The first 3 patients are at dose 1, and they're all, none of them experience toxicity, so they're all coded as the color green, and so you would escalate as a result. The patients at dose 2, among the first 3 of those, there was 1 toxicity, denoted with a red square. So then you would enlarge the cohort and go to 6 patients. There were no more toxicities, so you again would escalate here. Again, the third dose is similar. There's 1 out of the first 3 that have a toxicity, so you enlarge the cohort and keep going up. When you get to dose 6, there were 2 out of those first 3 that experienced toxicity, so the previous dose would be generally considered the maximum tolerated dose. So dose 5 here in this illustration would be the MTD. There are some drawbacks to this 3+3 design. It gives you a biased estimate of the maximum tolerated dose in the sense that it's generally going to be too low. Okay? In fact, and another concern is that the maximum tolerated dose is, because you're doing these cohorts of 3 and possibly an additional 3, it's specific to that 33% dose-limiting toxicity rate. It also generally tends to move fairly slowly through the doses because of the cohort sizes. But the advantages are that it's simple. Investigators can basically take it off the shelf and run it. There's no statistical modeling needed. I do want to mention one other phase 1 design here before I move on to some of the other phases of clinical trials. That's the continual reassessment method. This basically is you keep reassessing the dose response curve. So after each patient has a valuable outcome of whether or not they got a toxicity, a dose-limiting toxicity, you would refit a dose toxicity curve like we saw in the previous figure. So once you refit it, then you can re-estimate where that maximum tolerated dose might be. And then that's where you would put the next patient. You would put the next patient at that estimated maximum tolerated dose. There's a number of modifications to this principle of this continual reassessment method, but I mention it here because it is much more flexible than the 3+3 design and actually has much better statistical properties than the 3+3 design. However, it does require you to work closely with the closely in collaboration with the statistician, and that's why I put the smiley face here. We're happy to work with you, so we encourage you to come talk to us. Phase 2 trials. Phase 2 trials are basically trying to determine, you've already established that you have a particular target dose that's reasonably safe. So the next step is to determine if there's a reasonable chance of efficacy or biological activity. You also are interested in getting a little bit more stable estimate of toxicities and adverse events in a larger cohort than what you might have seen in a phase 1 trial. So at this point, when you do a phase 2 trial, there's often a single well-described treatment regimen being studied. So these are phase 2 trials are often single arm or single treatment trials. Again, they're still small sample sizes. 40 to 50 is fairly standard for this phase. And they're used to select the treatment for the phase 3 trial. Okay. So in terms of phase 2 trial, there's often a tighter inclusion and exclusion criteria than what you might see in a phase 3 trial. You're trying to establish that the drug has some biological activity, so you use candidate patients that are most likely to benefit from that treatment. Ideally, because you're using this as a screening tool for a subsequent phase 3 trial, you often want a quicker outcome measure so that you can make a determination quickly. Phase 2 trials are often done in a 2-stage design where you enroll a certain number of patients, make a determination of whether you're going to complete the rest of the enrollment of patients in that phase 2 trial or whether you're going to stop early. So the goals here in the phase 2 trial are, from a statistical standpoint, are really estimating the outcome. Okay? Estimating the outcome means not only do you estimate it, but you also construct confidence intervals so you know how uncertain you are about that estimate. Oftentimes, especially in the cancer setting, you're dealing with a binary outcome, yes or no type response, like a complete response to the chemotherapy, or not, or a partial response to chemotherapy, and those would have a success probability denoted P here. In addition to estimating the outcome, you're sometimes using this as a screening tool, so you want to try and establish whether there's potential efficacy here. And oftentimes this is done because you're only enrolling patients on a single arm. Oftentimes this is done by comparing their outcomes to some kind of historical control or a cohort of patients that have previously been treated. So from a hypothesis testing framework, you're testing whether the proportion or the success rate in this new cohort of individuals is equal to the historical rate of P0, or whether it's not, or whether it's greater than P0, for example. Equivalently, you can just look and see whether the confidence interval for the proportion contains that value of P0 or not. So here, the significance level of that hypothesis test refers to the chance that you find a treatment promising when, in fact, it just has the same outcome as your historical data. Here's an example of a phase 2 trial, again in this transplant setting that I mentioned I have some experience in. Here you're augmenting a high-dose chemotherapy regimen with an IL-2 activated autotransplant for patients with metastatic breast carcinoma. And so the phase 2 trial involved 33 patients with de novo or relapsed stage 1 to 3 breast cancer between 1996 and 1998. Their 2-year progression-free survival was 35%, the 95% confidence interval from 15 to 54%. The overall survival at 2 years was 78%, again with a 95% confidence interval from 62 to 94%. The other objective is to collect some toxicity data. There were 2 grade 3 toxicities in these 33 patients, indicating that the toxicity was reasonable for this approach. They also collected engraftment data, which is a particular outcome for the transplants, and all of them engrafted, so that was not a concern either. As far as assessment of a historical control, they had these investigators referred to 29 patients between 1993 and 1997, where the 2-year progression-free survival was 17%, and the overall survival was 61%. If you do a formal comparison of these 2 cohorts, 33 patients and 29 patients, you're really not powered to detect differences between those 2 cohorts. But oftentimes, we treat the historical control as just a fixed value. So from that standpoint, the progression-free survival of 17% is in the confidence interval, so that would suggest maybe there's not much benefit to this approach. But overall survival actually was outside the confidence interval, which would suggest there may be a benefit in terms of overall survival. So in this particular setting, you're kind of on the fence as to how promising this particular treatment is. But formally, it's not significantly different. In terms of sample size, how do we determine sample size for a phase 2 trial? We can consider it in a couple of ways. One is how precise is our estimation? How narrow is that confidence interval that we're trying to set up for that outcome? A larger sample size generally yields a narrower confidence interval. So you can specify a targeted width of the confidence interval or margin of error, which is your half width, and enroll enough patients to get a narrow enough confidence interval. Another way of determining sample size is from that comparison to a historical control framework, where you're looking for high power or high chance of declaring the treatment effective or promising when in fact the response rate is equal to the alternative, some kind of alternative. So here a larger sample size yields greater power, so what you need to specify in this framework is the null and alternative proportions, the significance level, and the power. So for example, this is an example from a treatment where you're where you're investigating a new treatment for treating grade 2 to 4 acute graft versus host disease after a bone marrow transplant. The outcome that they're looking at is a complete response to the treatment, basically a complete resolution of the symptoms. Steroids is the standard of care, and it has a historical complete response rate of about 35%. So they have a new agent that they want to evaluate, and they want 80% power to detect an improvement in that complete response rate from 35%, which is the historical value, to 55%. And so with that framework, if we specify a one-sided test and a significance level of 5%, then the target sample size should be about 35 patients. So from an investigator standpoint, what you want to think about is what the null value is, what the historical rate is, what kind of alternative you're trying to detect. Okay, the 35% is the historical rate, the 55% is the targeted improvement, and then what kind of power you want to be able to detect that improvement. And then the statistician can work with you to put together a sample size calculation. Sometimes these phase 2 trials are done in 2 stages. Basically, we want to minimize the number of patients that are treated with an ineffective treatment. So the way this is done is we choose a certain number, we enroll a certain number of patients in the first stage, and if we don't have enough responses in that first stage, then we would stop at that point and not continue enrolling the rest of the patients. If we have some minimum number of responses, then we would keep going. Okay. Doing a 2-stage design generally requires some kind of short-term primary endpoint, not a long-term endpoint. So here's an example. Suppose we want to compare a new treatment against a historical control that has a response rate of 10%. We want 80% power to detect an improvement in that response rate from 10% up to 30%, again with a significance level of 5%. So what this looks like is we would basically stop if we have 1 or fewer responses out of the first 10 patients, or we would also consider the drug not promising if we have 5 or fewer responses out of the 29 patients. So we're going to enroll 10 patients. If we don't get if we don't get 2 or more responses, we're going to stop there. If we get 2 or more, we're going to keep going to a total sample size of 29 patients. And then at that stage, we would consider the drug promising if we have 6 or more responses in that cohort. Okay. So this particular study has a chance of stopping early when the response rate is the same as the historical rate of about 74%. That's what that probability of early termination refers to. Okay. So this is one way you have an interim evaluation. You have some minimal criteria for proceeding on to the second stage. And then there's a particular chance of stopping early that's associated with that stopping rule. There are calculators for these kinds of designs that you can take a look at, and there's a reference to the website here. And you can see how those are put together. So I want to spend the rest of the time talking about phase 3 trials and the design features of phase 3 trials. The main things that we want to focus on is, first off, coming up with a testable hypothesis and framing your design. That includes what are the outcomes that you're going to look at, what is the patient population that you're going to look at, as well as assessing, help determining the design of the study, the importance of a control group, why randomization is important, and then some other techniques like blinding and data monitoring. So what is the question? Well, the question includes a number of features. It includes the treatment that's being compared, the primary outcome variable that you're studying, and the patient population that you're targeting. Usually in a phase 3 clinical trial, there's one primary question. It needs to be clearly defined and stated in the protocol. You can have a number of secondary questions, but you generally limit the primary questions to a single one. What is the primary endpoint that you're going to focus on? This is usually the main clinical variable of interest, which is most likely to be impacted by the treatment. It could be a composite endpoint. For example, when you're studying heart disease, you may be looking at reducing death from coronary heart disease, but you may also be looking at reducing the occurrence of non-fatal myocardial infarctions. So you can treat either of those events as a failure, so to speak, of the treatment. So that would be a composite endpoint. The response variables that you're measuring need to be capable of unbiased assessment, and sometimes blinding is one way to use that. Death is obviously an unbiased variable that can be assessed, but there are some others that may require review, and that's where blinding can be an important feature, and we'll talk about that shortly. It's also very important that the response variables can be assessed in every single patient that is enrolled in the trial. When you have loss to follow-up, when you have missed appointments, you don't want to set up your primary endpoint where you have lots of missing data. That's going to cause problems in the analysis and place a lot of doubt on the results and findings of the trial. So let's just consider an example of a primary endpoint. We'll consider the framework of HIV studies. Here the HIV virus destroys the immune system. Individuals then are subject to infections, which may lead to death. A lot of the treatments now may target the virus. They may target specific infections. There's a lot of ways that the treatment may be operating. But some possible endpoints you can consider would be increase in the CD4 counts, which is a measure of the immune function. Viral RNA reduction, which measures the amount of virus in the body. You can look at the time to develop one or more opportunistic infections. You could look at the time to death. And you could also look at a composite assessment of the time to first infection or death. So there's a range of possible endpoints you might consider in this setting. Now, which one is most appropriate? Well, it kind of depends on what kind of clinical trial you're setting up. If you're thinking about a phase 2 trial, 1 and 2 may be more appropriate. Some kind of measure of the immune system, maybe a good indicator of the potential of the treatment to work well in a clinical setting. Measuring the amount of viral load may also be a good phase 2 endpoint. Number 3 ignores the competing risk of death. That's the time to develop infection. If your drug reduces the incidence of infections but then causes other toxicities, then you are going to be missing out on an important aspect of the outcome. 4, which is death, is often of ultimate interest, but it actually may not be practical. The mortality rate in a lot of these HIV studies has been slowed down. Patients may have a long expected survival, so that may not be very informative. So a composite endpoint actually may be between 3 and 4 may be useful in this setting. It's very important, of course, when you're talking about an infection outcome, to specify very clearly the definition of an opportunistic infection. So it's very important in a phase 3 setting to be very specific about the endpoint definitions. But certainly many of these other variables are important as secondary analyses or secondary endpoints. And Of course, it's important to remember that secondary endpoints can be important. Here's a little cartoon for those of you who are staying awake. It didn't cure their allergies, but the treatment group did have 18% fewer cavities than the group taking the sugar pill. That's a toxicity, right? Cavities. Secondary questions here. Some secondary questions you might consider would be components of the composite endpoint. Okay, if your composite endpoint is death or a non-fatal myocardial infarction, then you may look at death and you may look at non-fatal myocardial infarction as two separate components as well in secondary analyses. There could be many other endpoints. There may be subgroup analyses. You may be interested in exploring whether a particular type of patient has a different response than other types of patients. Toxicities can be important secondary questions or secondary outcomes. There may be ancillary studies that you're going to tack on to a clinical trial as well. Surrogate outcomes are a variable that are not an ultimate, not measuring ultimate clinical benefit, but may be useful in predicting ultimate clinical benefit. So that is another possibility. With all these different secondary questions that can be done, it's important to consider the impact of multiple testing or multiple comparisons. If there's enough tests being done, the chances some are significant by some of them may be significant by chance alone, when in fact there's nothing going on, when there's no intervention effect on any of them. So you got to be very careful when you look at a large number of secondary questions that this may be an issue. In general, secondary hypotheses are better considered as hypotheses that shed light on the results or may generate new hypotheses, but they're not generally considered definitive results. So subgroup analysis is one particular issue. What does this mean? Well, basically you're wondering, does the effect of the treatment in a clinical trial, is that effect the same across all the patients in that trial, or are there particular groups of patients that have different responses to the treatment? One example of how this can go wrong is an old study looking at patients with acute myocardial infarction that were randomized to either placebo or aspirin. There was also a streptokinase arm, but I'm just going to focus on the placebo-aspirin comparison. This was published in Lancet in 1988, and the main findings was that mortality within 1 month was 9% on the aspirin arm and 12% on the placebo arm, and this was a significant finding. The editors of the article actually urged the investigators to conduct nearly 40 different subgroup analyses. And the investigators agreed, as long as they could provide their own subgroup analysis to illustrate the potential unreliability of those subgroup findings. And so this is what they picked. This is a subgroup defined by the astrological sign. So if they were born in the months associated with the signs of Libra or Gemini, then there was no effect of aspirin over placebo. Whereas if they were born in one of those other months, they had a very significant result. So anytime you look at subgroups of patients, you get increased variability in the results just by chance. And this is especially problematic when you look at large numbers of subgroups, and in particular small subgroups. So here we have an example of an excess of type 2 errors where some of the groups are not finding a difference, but you could also have excess of type 1 errors where you're finding differences where there really aren't any. So let's talk about an example of a primary question here. This is a study by the Southwest Oncology Group where they're looking at post-transplant therapy with a IL-2 versus observation after a autotransplant in patients with relapsed non-Hodgkin's lymphoma. The outcome here is progression-free survival. And they looked at secondary endpoints, including overall survival, as well as toxicity considerations. They had pre-specified subgroup analyses in the clinical trial protocol. So if you're going to do subgroup analyses, it looks much better if you pre-specify them in the protocol. Here they had a test for interaction between chemosensitivity and the outcome, so that was their first subgroup, and between histology and the outcome. So histology was the second subgroup of patients, or a second variable that was forming the subgroups. And they didn't find any significant interactions here. Okay. What about the patient population? So we've talked a little bit about the primary outcome and the primary hypotheses. The patient population also needs to be very explicitly stated and well-defined in advance in the protocol. The patient population may be different between phase 2 and phase 3. And in general, phase 2 refers to maybe people that are more likely to respond. Phase 3 may be a little more general population. The specification of the patient population clearly affects the reproducibility of the results and affects how other investigators can assess your study. It may affect the applicability of your findings to future patients as well. Certainly, there's a lot of indication that patients volunteering for trials are not the same as the general patient population. So just because you showed an important finding in the patient population in your trial doesn't mean it's going to translate to a broader population. There are oftentimes issues in terms of recruitment. From a strict sense, you'd like a nice homogeneous or similar population, but the narrower the population you specify, the more difficult it may become to recruit patients. So there's some trade-off between homogeneity and feasibility of recruitment. In terms of selecting the patient population, you certainly want to consider which patients have the highest likelihood of benefiting from the treatment. One way to think about this is patients, if you're looking at reducing the incidence of a particular event, you want to include patients that may have a high likelihood of that event occurring. If you're studying an anti-anginal drug, you don't want to enroll patients that only had one angina episode in the last 2 years. They're not at risk enough of having another episode. You may want to consider the benefits versus the adverse effects. This is a common exclusion is pregnant women. If you're looking at anti-inflammatory drugs, patients with a history of gastric bleeding may want to be excluded. You want to have patients with a low chance of competing risks. If you're studying heart disease, you don't want to include patients with cancer because of their competing risk of death from cancer. And ideally, you'd like patients that are going to adhere to the study protocol and follow participate in all the follow-up visits and take all the pills and all that stuff, but that's not always that easy to predict. So here's the basic randomized phase 3 design schema. You recruit your patients, you get consent, you randomize the patients to either treatment A or treatment B, and then they continue to follow that. Unfortunately, it's not always that easy. So why do we randomize? And what is randomization? Randomization basically is a process by which all the participants are equally likely to be assigned to either the intervention arm or the control arm. Okay, so they have an equal chance of being assigned to one of those two groups. Why is it important? Well, it's important because it protects us against bias in the treatment allocation and selection of patients. Okay? Essentially makes those groups comparable or similar on the average. And that means it balances out your prognostic factors, both the prognostic factors that you know about, which you might be able to balance out on through an adjusted analysis, but it also balances out the unknown prognostic factors. Now, randomization itself may still give you an individual study that may be imbalanced, but it makes the groups comparable on the average. Let's talk about this issue of selection bias. So here's an example of where you might see some selection bias. This is a pilot trial of high-dose chemotherapy with an autologous bone marrow transplant for multiple myeloma patients. Here, this particular study found a 3-year survival of 60%, and they tried to come up with a historical control. They looked at a SWOG, a Southwest Oncology Group, a series of 4 phase 3 trials of standard chemotherapy over a period between 1977 and 89. That had a 3-year survival of 40%. Okay? But there was an inherent bias in that historical comparison because there were somewhat different eligibility criteria. In order to be able to withstand the bone marrow transplant, the patients were generally younger. They were generally in better condition or better health than patients that were in these chemotherapy trials. When you restricted those SWOG patients to patients that were less than 70 years old and those that had good renal function, the 3-year survival was 60%, which doesn't make this initial treatment look quite as promising. So you can try and come up with the historical control, but you never know if you're adjusting for the right factors and getting a real good comparable group. And that's why randomization is so important. It automatically guarantees that you get a comparable set of patients. How do you do randomization? Well, one way to do it is just flip a coin. Okay? The problem with flipping a coin is that you may actually get a sequence of the same result. Okay? And in fact, you could end up with imbalance. Just by chance, you may end up with 3/4 of your patients on one arm and only 1/4 on the other arm. It's not likely to happen, but it could happen. And you don't want to leave that kind of outcome up to chance, so to speak. So an alternative way of doing the randomization is by setting up these random permuted blocks. So with random permuted blocks, you're ensuring balance across accrual time. And so a block of 4 patients, so what that means is you enroll patients in blocks, say in this particular example, it's blocks of 4 patients. So what that means is in each of those 4 patients, you have 2 patients assigned to treatment A and 2 patients assigned to treatment B. And the part that's random is the order of those 4 patients. So the first block of 4 patients, the first one gets A, the second one B, the third one B, and the fourth one A. So that's a randomly generated sequence of 4 of those 4 treatment assignments. The next block is BA, BA. So that's another randomly generated sequence. But you ensure that you have balance after each 4 patients in terms of the number of patients assigned to each treatment. Another important aspect of randomization is the idea of stratification. So stratified randomization ensures balance across important covariates, which are maybe known to be associated with outcome. So what can happen is even with these random permuted blocks, you may end up with all the good risk patients on treatment A and all the bad risk patients on treatment B just by chance alone. And again, it's not likely to happen, but it could happen. Or there may be a little bit of imbalance. And so you don't want that potential for imbalance on an important known prognostic factor. So stratification, where you set up these permuted blocks within each group of patient or each stratum of patients, guarantees that you have balance within each stratum. Oftentimes, stratification is done by center, so you set up those blocks within a center to ensure that each center has balance in the treatment assignment. Another important randomization issue is when do you randomize patients? Okay? The general principle that you want to follow is you do it as close as possible to the treatment itself so that you can minimize dropout. So the way that the standard way of analyzing phase 3 clinical trial data is according to an intention to treat principle. What this says is that all eligible patients are analyzed according to the arm to which they're randomized, regardless of what treatment they actually get. So if they're assigned to treatment A and they get treatment B, they're still analyzed in the treatment A arm. Okay? So even if they deviate from the therapy that they're assigned to, they still are still are analyzed in the group that they're assigned to. And the reason for this is that it avoids bias or minimizes bias in the conservative fashion. For example, if good risk patients who are assigned to treatment A maybe decide, well, treatment A is a little more toxic, I don't actually want to do that, and they switch over to treatment B. Okay? If they do that, then you will have, and you compare them according to the treatment that they actually got, then you are getting some selection bias into the comparison. Okay? Whereas an intention to treat principle avoids that selection bias. So here is, I want to revisit this SWOG non-Hodgkin's lymphoma trial of this IL-2 post-transplant. Okay, so the question here is, when should the randomization be done here? Okay, so this is an intervention that's occurring after an autologous transplant. Okay, so what they actually did was they registered patients prior to the transplant, but they didn't randomize until later. They randomized sometime between day 28 and day 80 post-transplant. And the reason that they did that is they didn't think everybody would actually be eligible for receiving the IL-2 treatment. Okay? Not everybody who undergoes the transplant procedure itself will get to the point where they can actually get the IL-2 treatment. Some of the reasons that they might not be eligible is that if the disease recurs or progresses, if there's some kind of serious toxicity. So they wanted to avoid losing all those patients, okay? If they had randomized right at transplant, many of those patients would not have been eligible to actually get the IL-2. But because they're randomized, according to an intention to treat analysis, they need to be included in the analysis, okay? Even though they didn't get the treatment. So that is a problematic comparison. So that's why you ideally want to randomize as close to the actual treatment as possible. Minimize dropout, allow as many people as possible to actually get the treatment. So in this particular case, they had 394 patients initially registered, 376 were eligible for the auto transplant, but they only actually randomized 194 of them, about half. Okay, and the reasons that they weren't randomized, there were 46 that refused to be randomized at that point. So they probably would have been non-compliers to whatever they were assigned to if they had been randomized up front. There were a number of grade 4 or 5 toxicities, and there were some progressions. Okay, so ideally you want to randomize as close to when the treatment starts as possible to minimize a period of where patients can drop out or other things can happen to them. And make your intention to treat analysis as close to an as treated analysis as possible. Another issue in the design of clinical trials is that of blinding. Here, the doctor is actually a blinded treatment here. Your doctor will be here in a minute. I'm just a placebo. So it's not the real doctor. So why do you blind the patient? Okay. Well, there's a number of reasons. One is that, quite simply, there may be a psychological benefit of being on the new treatment. Okay. It's hard to assess how much impact that will have, but there certainly are some suggestions that can have an impact. The attitude toward the treatment can affect a lot of other factors, not just a direct psychological benefit, but compliance with the therapy, compliance with other ancillary care, attendance for evaluations, dropout rates. Whether they know or think they're on a particular treatment can affect a lot of things. In fact, it may affect the response. Why do we blind the treatment team? Again, knowledge of what treatment patients are receiving can impact a lot of things that the treatment team can do. It can impact modifications to a dose of a drug. It can impact how intensely they examine the patient, when they discontinue treatment, any kind of ancillary care or secondary care that they are giving the patient. And if the patient is blinded but the treatment team is not, there's always a potential for breaking the blind from enthusiasm for the treatment. And then as far as the evaluator, the person that's evaluating an outcome in of a trial needs to be blinded if possible so that they have an objective response, an objective assessment. Is blinding always appropriate? Well, certainly not always appropriate. From an ethical standpoint, you want to consider, is there any undue harm to the patient? There are situations where you may need to monitor specific drug levels as the treating physician, and especially if there are potential interactions of drugs. So you may need to not be blinded to the drug. Surgical trials are ones that are often not blinded because of those kinds of difficulties. From a practical standpoint, the treatments need to be similar dose schedules, similar pills. The informed consent is sometimes harder because the patients end up not knowing what they're getting, and it's administratively more difficult as well. Another important issue of a clinical trial is, especially a phase 3 clinical trial, is the issue of sample size. Okay, the basic idea of having a sample size calculation is to consider the fact that patients respond differently to treatment. So we're interested in what's the collective effect of the treatment on a patient population. And the simple fact is that larger sample sizes increase the precision of the estimated treatment effect. So when we do calculations, we do them based on the primary endpoint of the study. Okay, that's the definitive clinical endpoint, and that's how we power the sample size calculation. So what you need to do is you need to specify what's the likelihood of detecting a significant treatment effect of a particular magnitude, and that's what we call power. So as an example, we might design a study where we want 80% power to detect if a new treatment increases 2-year progression-free survival from 40%, which is what we think the control arm might be, to 55%, which is where we are targeting the improvement in the treatment arm. Okay, so those are the kinds of things that, as a clinician, you need to be able to specify when you're working with a statistician to develop a clinical trial protocol. You need to specify the type 1 error rate, the power, and then in this particular example, the success proportion for the control and for the intervention. There's a formula here. I think I'll kind of gloss over that and encourage you to either consult some tables. There's some software or calculators available on the internet, and there's some links here. There's also, when you deal with different types of endpoints, the calculations are a little bit different. When you're looking at continuous normal outcomes, survival outcomes, those kinds of things, they all have a little bit different sample size formula. Most importantly, I encourage you to consult your statistician and consult them early. Another important aspect of a clinical trial is that of data monitoring. Okay? Phase 3 trials generally have a data safety monitoring committee assigned to ensure that the patients in the trial have adequate safety and that the study is conducted with integrity. They generally meet fairly regularly, every 6 to 12 months, depending on accrual, to review the data. And there's a number of justifications for early termination of the study. If there's unacceptable toxicity, they may recommend closure of one or more of the arms. If there's accrual issues, they may decide that it's not ethical to continue enrolling patients on a study that's not going to be able to be completed. And then sometimes the design includes specific stopping rules for efficacy or futility. If the treatment appears effective at an interim time point in the conduct of the trial, we may decide to stop early. Okay, there's oftentimes, in order to help the Data Safety Monitoring Board, the protocol may include specific toxicity stopping rules that can assist the DSMB in reviewing the toxicity outcomes. Give them some frame of reference for what's excessive or what's not. Okay. Usually toxicity monitoring rules focus on short-term outcomes, maybe grade 3 to 5 toxicities within a month after the treatment. It's important to understand the expected toxicity rates because that can provide them a framework for deciding what is excessive and what might not be. Kind of parallel along with this idea of data monitoring is a particular type of clinical trial design called a group sequential design. Here, the decision on the clinical trial outcome is made sequentially based on groups of patients that are entered in the study. You can specify termination of the trial at an interim analysis or an interim evaluation, either for greater than expected benefit of the treatment, worse outcome for the treatment, if it's worse than the control arm, or possibly for futility. If there's little or no chance of obtaining a significant finding by the end of the study, you may decide to abandon the treatment. Stopping early, and these group sequential designs generally require some kind of a short-term endpoint. And the way that it works is we generally need to adjust the way that the hypothesis test is done at each interim analysis. We essentially are adjusting the significance level at each interim analysis. Here's an example. This is the beta blocker heart attack trial. This is an example published in 1984. The primary comparison was comparing mortality rates using a log rank test. So in May 1979, they conducted their test. They got their test statistic. It's a Z statistic here, and it was 1.68. In October of 1979, it went up to 2.24. So note that the standard rejection rule, or way that you would do the hypothesis test, would be to reject the null hypothesis of equal mortality if that z-statistic was up above 1.96. That's the usual cutoff that we look at. That corresponds to a 5% significance level. And in fact, we jumped over that in October. They jumped over that in October 1979. But because they're looking at the data multiple times, there's a stronger requirement of determining efficacy at the earlier analyses. Okay, and so that the boundary for that requirement is given here in the black lines, and so you can see that the study actually didn't meet that requirement until October of 1981. So there's a penalty to be paid for looking multiple times, and in terms of how you adjust the analysis, but it allows you to make decisions earlier than the end of the study. Some basic data items and forms that should be included in the protocol. You need to assess the basic variables: eligibility, the evaluability, summary of the treatment, and the summary of the outcomes. The forms generally need to include some kind of study-specific flow sheet to assess their outcomes, an off-treatment notice or notice of death, pre-study form to capture baseline characteristics. And then I want to close by presenting just a sample protocol that was put forward in the Friedman book on clinical trials published in 1998. They propose the following sections, and you can look at it in more detail, but I'll just kind of leave it there. A background of the study, objectives, which includes the primary, secondary questions, and so forth. The study design, which includes the population and inclusion-exclusion criteria, sample size calculations, how the enrollment is conducted, how the intervention is conducted, the schedule of follow-up visits and what is assessed at each of those follow-up visits, how the response variables are ascertained in terms of the data collection and data forms, how the quality control is done, and then steps for the data analysis, procedures for the data analysis, which include if there's plans for interim monitoring of the data. And then if there's administrative organization that needs to be spelled out here, that can go in there as well. So thank you for coming to this talk. I just want to mention in the last couple slides some of the additional features. I just want to remind you of the resources of the Clinical and Translational Science Institute and the resources of the Biostatistics Consulting Service, which are available to all of you. There is free drop-in consulting, statistical consulting, and there's a schedule here. And there are some additional upcoming lectures which I encourage you to attend, and the schedule is given on this slide. So you should have all that information in your handouts. Thank you.